Hi.
Yay! Oh my God, it's so good to even though
How
this
are you?
isn't in real life, it feels like we're hanging out. So
Yeah.
I'm so happy that you're here. How are
Thank you.
you?
I'm good. I'm good. How are you?
I'm good. I mean, it feels so weird to ask and answer that question right now because
Yeah.
life is crazy.
Yeah.
So, for those of you who are joining us from Chronicon, we have Dr. Darien here, and you might have already gotten to see him speak at our live Chronicon in October of 2019. So, thank you all for joining us, and thank you, Darien, for being here with us today.
Of course. I always love joining you.
It's such a pleasure. And I have to say, just like a little fangirl moment before we dive into our conversation, that I have been a fan of Darian way before the coronavirus. Okay. I know now he's like the hottest commodity, and you just, you're on every news outlet and every live, and you are the person that people want to hear from the most right now. But you have been doing your bus stop med for
Yeah.
so long, and anytime we would run into each other at a party, I'd be like, "Oh, that latest case, Darian." It's like an episode of Scandal, guys.
Yeah.
So
I feel like people are like, "Oh, when did you start doing this?" And I'm like, "I've been doing this for a while."
I'm doing this for a
So,
long time. Yes.
yeah.
So anyway, so just to kind of get people a little bit more familiar with you, so you are an ER doctor here in New York City, right? So how long have you been a doctor? How long have you been doing this?
So I started my training in 2015. That's when I graduated medical school.
Yeah.
So it feels like it feels like it's been since yesterday. And now for a year, I've been a supervising attending physician with Northwell Hospital. And so that's where I've been.
That's amazing.
Yeah.
So with everything Corona, I mean, we obviously, want to hear from you about that. Just personally, like, how have you been doing? What has this been like for you?
Well, it's been every day is like a different day.
Yeah.
I think every day, every ER doctor is trying to figure out like how to manage this crisis, but also how to take care of ourselves.
Yeah.
I'm sure you've heard that we unfortunately lost an ER doctor.
Did.
And it's been one of those moments that make you take a step back and make sure you ask yourself, am I taking care of myself? And that's what we have to keep reminding ourselves.
Yeah. Yeah, I did see that news, and it's a really devastating time, but it's also so interesting how we're supposed to navigate like such devastation and such trauma. And you're in the eye of it all the time through the work that you do. So, are there things that you're doing to sort of take care of yourself? I mean, we need a little bit more than essential oils right now. Like, it's just like not gonna cut it. As much as I'm like the essential oil self-love queen, I'm like, we need some extra stuff. So, what are you
Yeah.
doing?
I think I've just been doing everything that everyone else has been doing, like making sure that I keep myself on a schedule when I'm not working, doing simple things like getting up and eating breakfast and making up my bed, and trying to find time to exercise and limit my exposure to triggering evidence and findings. Like, I feel like that's what I try to do on a daily basis. I
Mm,
fail every day, but I also remember that every next day is like a time for a resolution. So,
mm.
so
I love
just not
that.
being hard on myself.
Yeah, I love that. And I think creating a schedule is super important. I appreciate you saying that like you still fail at that because
Hmm.
I'm such a regimented, scheduled person. I love having a schedule, and I thought I would go into quarantine and just be like, yes, 7 a.m. yoga on YouTube and 4 a.m. Zoom meetings or whatever. You know what I mean? Like I just
Hmm.
thought I would be so regimented, and I'm really finding that so hard.
It's really hard because, let's be honest, I
Yeah.
feel like what we're not acknowledging is that many of us are going through what we would define as like an adjustment disorder. And it's
Mm,
like a clinical a psychiatric term, which means essentially like when your surroundings change, you go through an adjustment that you may not be able to handle, and you
mm,
may be experiencing feelings that you've never experienced before. And people have to acknowledge that many of us are feeling that way. So the psychological stress is not always represented or identified as much as we see in the medical side of things. But the psychological stress is really important because it's tied to everything else. And so
Wow.
I really try hard to pay attention to that.
That's so helpful. So you're saying that even because that's something I've been battling with a lot. Like, I'm very lucky that, you know, my family is okay right now, that they're healthy, and I am okay, right? So I've been really sort of beating myself up when I have a hard day, because I'm just like, how can you be upset right now? Or how can you have a hard day? There's so many people that are dying and that are going through such trauma, or, you know, people like you who are in the middle of all of it. But you're saying that there is an actual like disorder or an actual clinical reason for that.
Yeah, if people can imagine or relate, whenever you have a big move in your life, or whenever you have a big transition, maybe you graduate from college or graduate school, or you change jobs, you have a time when you feel unsettled. And that's what is happening to all of us. You know, it's been many of the things that we find relaxing, comforting, have been taken away. And when that happens, it's really a stressor on your emotional and psychological state that you have to identify.
Oh, everyone can just like take a deep breath.
Yeah.
I really appreciate that.
Yeah,
that makes a huge, huge difference. And so you're working now, and obviously today you're not in the hospital, but what does it look like right now? I know initially it just felt like pandemonium, and I'm sure it's still incredibly hard. It feels like it's not as chaotic, but maybe that's wrong. So what is it like day to day in the hospital right now?
So I would have to say that definitely the idea of, or the chaos that we did see maybe 2 to 3 weeks ago has substantially decreased. And what I try to help people understand is that the volumes to the emergency rooms have decreased. 2 to 3 weeks ago, it was really fascinating because it was almost as if everyone had gone through the same symptoms at the same time and presented to the hospital on the same day. It felt like that. Our ER was packed. We had no space to move patients upstairs, and it was really stressful. And then luckily, I think people specifically in our city here in New York started paying attention to like shelter in place and the real understanding of what social distancing is. And we saw a significant decrease 2 weeks after publicly people started to educate. However, the unfortunate length of stay for someone who is admitted to some place like the ICU is about 2 to 3 weeks. So if you can take that and imagine that, that means that our hospital is still full of people who are fighting to live and who are just trying to survive and thrive. And that's what we're trying to help them do right now.
Okay, so that makes a lot of sense. So you're saying that the shelter in place and the social distancing did, even though there's significant damage and trauma that's happening and that's still being worked through, that it did make a difference, and that
Absolutely.
we need to continue to do it, essentially.
Okay. What I try to help people understand is, number one, I think that we're going to start to see the beginning of the light at the end of the tunnel.
Okay.
But we have to also understand that on the other side of the tunnel is what we should define as our new normal.
Okay.
And so it won't be for a very long time just go right back to what you had before. I think things like concerts and movie theaters and packed restaurants are going to have to sit at the wayside until we figure out how to appropriately organize ourselves to decrease the risk of transmission and, unfortunately, having COVID-19 resurface, which is inevitable. But the goal is to decrease the amount of people that get it the next time we have another surge.
Okay, so it sounds like, you know, maybe in the coming months, it'll be more like social distancing, light, you know, going out, maybe tiny gatherings if it's very safe with people you know who have been isolating, but not these huge gatherings. And then there'll be another kind of sector, maybe next year or the end of next year, or a vaccine or something.
Yeah, so a lot of people have hopes in vaccines, and I definitely have hope myself because I'm an optimistic person. What I have to be realistic though about is the fact that a vaccine takes a lot of time to develop, to distribute, and to make sure that it's accurate. And that is something that probably won't happen in this calendar year. But what I can hope for is that we'll finally, hopefully one day, have enough testing. I keep talking about this and repeating myself because I define it as something that we call low-hanging fruit. I think that the problem is that the communication from above, from a federal standpoint and from a media standpoint, is that we have too many things that we think are going to fix this problem, when in reality, we have to focus on the main thing that is the issue, which is testing and contact tracing.
Mm-hmm.
And so when we have that and we can establish that we have enough of that, then we can start to talk about when to take our next steps.
Okay, that makes sense. So can you help me understand, just for anybody who's out there watching, I hear about testing a lot. I understand the basics, like it's important because some people don't have symptoms, but they might actually be carrying the condition. So it's important from that level. You know, and if you have symptoms, I guess you should get tested so that you know for sure that that's what you had. Like there's just so many different things that we're being told. So that's sort of the basic of, I'm like, okay, people should get tested, but why is it really important?
So the reason why testing is important, and the reason why I still am trying to figure out how to tell people about it more and more, is because right now we're only testing people who we would define as high risk.
Okay.
So for example, if you or I were to walk into a hospital, presumably without a fever and without symptoms of having a cough or shortness of breath, then we probably would not get tested in New York in most facilities.
Yeah.
Many people are able to get tested without symptoms, but that's a discussion of privilege.
Mm-hmm.
The majority of people who do get tested are the people who I probably already know have COVID. So I'm literally just testing them to be able to cohort or put them in a specific place in the hospital.
Mm.
But until we can have the ability to say everyone who wants a test can get a test, and the goal is really to test around 15% of the population. And this has been decided by epidemiologists and scientists at Harvard and the World Health Organization.
Mm-hmm.
Once you have testing to that degree, then we can say, okay, we know exactly what we're dealing with. We know where the positive people are. We identify communities that have hotspots, and we attack those communities in terms of prevention, isolation, and treatment. And then we prevent it from spreading to other communities.
Okay.
But if you don't have testing, then you're just fighting the fighter with blindfolds on. And it's the only assimilation that I can come up with to help people understand how medicine and testing works.
Okay, that makes sense. That makes so much sense. We actually have questions. I didn't even realize people were submitting questions.
Awesome.
So we have someone that just asked, is it true that ventilators are doing more damage than good? I have heard conflicts about this.
That's a great question.
Yeah.
So recently that study came out, unfortunately, from Northwell Health, which is the company that I formerly clinically work for.
Mm-hmm.
And it basically showed that the majority of people, 80 to 90%, were having high rates of mortality, were dying, who were intubated. However, I try to explain to people that when you are making the decision to sedate someone and to put a breathing tube in them and to put them on a vent, those patients are usually already critical. And unfortunately, we just simply don't know about what their outcome would be if we did not help them with the ventilator. However, this information helps me as a clinician and other providers help make an informed goals of care discussion with patients and their families. Okay. Now, it's really difficult because families aren't allowed in the hospital. So a lot of my time before I decide to intubate and ventilate a patient is spent really explaining to that patient what are the likely outcomes and making a possible decision. Hey, I know that you need this vent, but you probably want to talk to your family. Would you like to wait longer, given what you know, in order to make your decision and have a really educational discussion with your family, or would you want to be intubated right now? And like I say to all my patients, my job as a physician is to educate you, but not make the decision. And that's what I think is what we should all strive for as providers, is to really provide all the information and to help you walk through the options, but I can't and I shouldn't make the decision for you unless obviously you can't make the decision or you're in a state that you can't make that decision.
Yeah, I really appreciate that. And something that I've always really appreciated about you specifically, which I think people listening, I really encourage people to look for this in their physicians, is that you really do talk to your patient. I mean, I've called you with medical stuff before. I'm like, I have no idea what's happening. Darien, can you just help me? And you're like, yes, no problem. I'm just gonna step out of my dinner that I'm having right now and just have a conversation with you. But you talk to your patients like we are educated. And I really mean that, because a lot of times doctors don't talk to their patients with that respect, that they, have rights, that they should feel empowered, that they should feel safe. Those are all things that I hope all of you are looking for with your doctors. And I really feel that you do such an incredible job of that.
Oh, thank you.
It's
Thank
true.
you.
Okay, I'm going to have to pull this closer to me so that I can read these questions because I don't have my glasses on. So any specific data coming in regarding immunocompromised and COVID illness outcomes?
Great question. So a lot of people ask this, and I'll reference patients who are, for example, on chemotherapy and receiving treatment. Those patients are immunocompromised. I don't want to get this confused with patients, for example, who have chronic HIV and are obtaining treatment. Someone who has chronic HIV and is obtaining treatment and has relatively normal, what we call CD4 or those fighting white cells. If you have a normal amount of those, then we put you in that category of patients who are not immunocompromised. You're actually immunocompetent. But if you're not taking medications for your disease, such as HIV, and you are immunocompromised and you don't have much of those white cells, then we put you in the box with patients who are immunocompromised, the same as patients who are obtaining chemotherapy. So those patients who are immunocompromised are at higher risk of getting any infection, which could be COVID-19. But I don't want to compare or confuse patients who have well-treated HIV.
Yeah, no, that's really helpful because even when this first started happening, I was really nervous because I have 2 autoimmune diseases and then I'm also on an immunosuppressive medication.
Yes.
And I was like, does that mean I'm immune compromised? Like, you know what I mean? Because sometimes people will say, well, you have autoimmune conditions or your immune system is being suppressed so that it's actually reacting. You know what I mean? I'm not a doctor, so I'm a patient, so I don't know all the words for everything. But there's a difference people have been bringing up.
Yeah, so I encourage people, if they're on multiple medications or if they're getting treatment, to have a really close conversation with their doctor. Of course, I'm assuming that if you're getting treatment, you're having a conversation with the doctor regularly. And really, it's really important to talk to your doctor and have them explain to you what types of medications you are on. Some medications help your immune system. Some medications decrease your immune system. So that's a really patient-to-patient discussion that has to happen on an individual basis.
Yeah, that's great. That's really helpful. So as I said, when I was talking about this in my Instagram stories, Dr. Darien is a doctor, but he is not your doctor. So make sure that you consult your physicians and your doctors and do your due diligence on your end as well. So I appreciate that. Okay, so can you speak on the effects of COVID and, I don't know how to say this, ischemic CMAs? Do you know what that is?
No, what is that? Can I see it? Let me check.
I don't know if you can see it.
I can see questions.
CVAs.
Oh, ischemic CVAs. Okay.
Thank God.
So, yeah.
My glasses are across the room. So yes.
So I'll help you understand this.
Thank you.
Ischemia means lack of blood flow, and CVA means cerebral vascular accident. And so that is another word for a stroke. Okay, so we use ischemic CVA to identify a specific type of stroke.
Okay.
You can have 2 main types of strokes. You can have one where you have a lack of blood flow, that's ischemia, or you could have one where you bleed, unfortunately, from something like an aneurysm, and that is a hemorrhagic stroke. So bleeding stroke versus ischemic stroke. Now, the question is about ischemic CVAs, so strokes that are caused from presumably clots. Yeah. And I shared this today in my story because what we've been seeing is that there is an increased rate of patients who have been suffering from clotting. And unfortunately, that is related to patients who are having strokes. What has been seen in the New York Times and other articles is that younger people who technically have no medical history and are presumed to be healthy are coming in with stroke-like symptoms and are found to have relatively large strokes in their brains. This is a small amount of people, but any amount that is more than normal is concerning, and that's why we talk about it. Yeah. But I want to caution people to not have the anxiety of the possibility of getting a stroke because, again, it's still rare. Yeah. But this is based off of the idea that the virus causes an inflammatory reaction, and that increases all of your clotting factors, which normally help you stop bleeding. But when that is upregulated and out of control, that increases your risk of forming a clot, and that could be inside of your brain. And so that's what we're seeing. Wow. Inside of the hospital, and those are theories to why that's happening. But again, this is rare. We don't yet have a reason specifically, although we have many assumptions, and we're managing them as best we can by relating it to information that we know from before COVID.
Yeah. Yeah. I mean, this right now is just, there's so much information coming in
Yeah.
right now. So it's, I mean, even just with my medication that I'm on, I know when I'm evaluating things, I'm like, well, okay, it's been around for 25 plus years. So this means that it's okay. Or I've seen 1,001 studies on this. So I know how to, react. Obviously there's rare cases, but I know kind of how to navigate my health because I have all that data. So what are we supposed to do with the fact that we don't have that privilege right now?
It's really hard because a lot of people ask me about like things like immunity, and I love the question when people ask about, well, what chronic things can happen after you have the virus? And then I have to remind people that this virus has only been known to exist since
Yeah.
December of 2019. So we're only 5 months into a new virus. So there's no way anyone can tell you about chronic conditions. And if they are,
Yeah.
they're poorly informed, and you should probably remind them that we've only been fighting this since December of 2019. And so what we can do is we can use information that we have from associated or other viruses that are similar.
Okay.
And so the coronavirus, specifically the COVID-19 virus, belongs to a family of viruses that includes the MERS virus, as well as the Middle East Respiratory Syndrome, as well as SARS, which we know from the 2003 outbreak. And we did a lot of research on those viruses to try to stop those outbreaks. And in many ways, it was successful in terms of stopping them. But I will say, to the fault of now, I think that because those viruses kind of stopped themselves with the efforts that we had applied, we kind of stopped the research in those worlds. And now we have to pick up the ball and try to connect what we left off. And so that's what we're trying to do now.
I hear what you're saying. That makes a
Yeah.
lot of sense, that we should have kept going.
Yeah. I mean, and this is, if anything comes out, there's many things that will come out of this, including ideas and information about the importance of public health and prevention.
Yeah.
But if anything comes out of this, it's the idea that you need to keep preparing and you need to keep funding science, because without science, you're going to inevitably repeat history. And so I hope that as a community, as a society, that we start respecting science a little bit more.
Yeah, I hope so too.
Yeah.
This person who asked that very intelligent question about the strokes, which is why I did not understand, is saying that they're saying thank you, and they've seen 4 CBAs in their ICU in 30 to 40-year-old patients. So that's why they were asking. So that's super helpful. So one of the things I wanted to ask you about is, there has been a lot of coverage and talk about how communities of color are being disproportionately affected by this virus, and especially the Black community. But I want to know, first of all, have you noticed that, witnessed that firsthand in your ER? And then I also want to talk a little bit about, if you are a person of color who's experiencing, this virus, or you're feeling like you're nervous in an exaggerated way, in a way that's a little bit more tense maybe than people around you, like what can we do about that as a person of color navigating this?
So unfortunately, it's true. And disparities, which are differences in health outcomes due to people's appearances, such as race, have always existed because of inequities or issues within the societal structure that inevitably causes us to be more at risk.
Yeah.
I always try to tell my medical students and my residents, people of color aren't born with chronic diseases. And so that narrative and that idea has to be erased in order for you to properly look at someone. This applies to many different problems. Notably, the overcrowding of the hospital leads to inevitably us making decisions, trying to be utilitarian or allowing everyone to have equal opportunity so that we can save the most people. But a lot of our utilitarian decisions are based off of comorbidities. And many people of color, specifically Black and Latino people, are more at risk for having comorbid conditions. Therefore, they are more at risk for not being able to obtain the same level of care as others. And so I think in order to solve that, we need to first acknowledge that. Recently, the last time I checked, 28 of the states have released data regarding the differences or disparities that exist, Black and brown people relative to white people in terms of the COVID-19 virus. And 20 out of 28 of those states had Black people doing worse than white people comparative to the overall population within the study that it was done at. And that's a really, really alarming number, but also we would expect that just because of everything I just said.
Yeah.
So whenever I see or try to advise on people who are trying to look for suggestions, I try to make sure that if someone is asking a question, we must not ask the people who are suffering. And so a lot of times we're always framed to ask ourselves, well, what can I do? You know? And I think that that's why I get frustrated with statements from public officials about Black people and how they can do better and not drink and not do drugs. That is wrong narrative that you should apply as a public official, because what you're doing is you're putting the onus on the people who are suffering. And what we really should be doing is putting the onus on society, leaders of society and communities, and understanding where they need help. And many of that lies in testing and treatment, coverage, and access. I've seen these photos from the 4 train, and I know that majority of the people who are on those trains going to those jobs that are essential are Black and brown people. And if we don't acknowledge that these are the people who are vulnerable, then we may not realize what the problem is until it slaps us in the face and there are more Black and brown bodies on the ground. And so to answer your question, I don't have a specific answer always to each person. What I can say is that I'll continue to speak about this issue and make sure that leaders understand what the actual problem is and make sure that they phrase their statements and their ideas appropriately. And then to any person who is of color, who is struggling, you have to be an advocate for yourself while we try to figure this out. And that is, if you feel like something isn't right and you feel like it's in your gut, then you need a second opinion. Obviously, not everyone is privileged to be able to get a second opinion. We do things in the ER, like send people home, and we say, if you have a problem, come back. But we don't acknowledge like the high cost that it is to come back and see an ER again. That's something that I think is really frustrating. But if you're fighting for your life, I don't know if you have any other choice during this moment to get a second opinion and to document and to do well in terms of bringing other people in the conversation. Even if someone cannot be there, call people, put them on speaker, and make sure that someone else is helping, listening, and asking questions. Because I think that that's really where we are right now. Unfortunately, I don't have like a specific answer, but.
No, that's actually very helpful, because this is a systemic issue. This is not a COVID-19 issue. This is, as you're saying, this is a systemic issue. This has been happening for countless years, and it is intrinsic in the nature of our culture, of our world, really, but especially in the United States. And so, yeah, I completely agree with what you're saying. And I think I'm so grateful that we have someone like you who can speak up, who is doing work on the front lines and can also be an advocate for people that don't necessarily know how to advocate for themselves all the time, you know. And I think the tactical advice of calling someone, if you feel that anxiety about, like, you know what, I've been to the doctor before, they don't always believe me because I have these 4 characteristics that they've written off as whatever, or they've devalued me in some way, which is completely inappropriate. Yes, calling someone, or just having people in your life, even if it's just one person, know that you are experiencing that anxiety and you're having to go into, you know, this hospital or this situation.
Yeah, it's sad because I've done a lot of diversity training, and I try to help people understand diversity training isn't just for those who are not diverse. And we all should be in diversity training, because a lot of my decisions are formed by the training that I had. And unfortunately, much of the training I had were by cisgendered white older men. And so a lot of my cognitive ideas about patients and their presentations are formed by the people who taught me. And so many times I have to stop myself and ask myself if I would do something different if this patient looked differently. And unfortunately, sometimes the answer is yes. And then I have to stop and realize why I'm making that decision. And unfortunately, I think, is that we make sometimes a discussion of race and racism such a divisive discussion that it leads people to feeling uncomfortable with asking themselves those questions that are really, really important. So I think we have to all do it together in some way.
Yeah, and I think that question of like you ask it with your patients, but I think as human beings, you know, we could ask that of ourselves constantly throughout the day. Would I be treating this person differently? Would I be gossiping about them less? Would I have given them a raise at their job? Would I have been doing, you know, list out all the things if their race was different? Yep. And I think that is, or if their gender was different, right? Like,
absolutely.
It's such a powerful question. And yeah, I'm so glad that we got time for this today. This has been so nourishing for me just to be with you, first of all. I was like afraid to ask you at first because I was like, oh my God, everybody wants Dr. Darien. He's the hottest commodity in the ER right now. I don't know. You're just so gracious and just
thank you.
right away. And I really Really appreciate it. And I know our Chronicon community loves hearing from you and loves that, you know, they have you to look to and all the hard on the side. So I appreciate it so much, Darien. Is there anything you want to leave our crew with before you go?
I hopefully we can do this again, and so we can have an update. I think that this is a really, really difficult subject because as data comes in, decisions and practice will change. And we've seen that with medications like hydroxychloroquine and remdesivir. And now we're talking about medications like Pepcid and other medications and hormonal management. And so I just want people to understand that we are trying to figure things out as much as they are. And you have to realize that doctors are also human and that mistakes will be made. So it's important to make sure that you help correct them. And I love being called out, and I hope people continue to do it. But if a doctor doesn't love being called out, then you should probably find a new one.
Whoa.
Yeah.
Mic drop on that. I've never heard a doctor say that. I've heard patients say that before, but I've never heard a doctor say that. So
well, it should be that way, you know?
It really, I completely agree. I think it should be a collaborative process. So yeah, I love the idea of doing this again. I really do. I think it is really important. I noticed, and also for those of you watching that are from the Chronicon page, please follow Dr. Darien because he does, first of all, these bus stop meds, I'm telling you, better than an episode of Scandal. Like, you are on the edge of your seat. You're just like, and then what happened? And then what did he do? And then how did he show? It's just the best. And yeah, and I do love the idea of doing this again and just keeping our communities informed and making sure that we highlight topics that are so important. And I so appreciate that we have you to have those conversations with. So thank you so much, Darien. I'm going to let you enjoy the rest of your evening.
You too.
All right. Have a great night.
Mwah.
Okay.
Bye-bye.
Bye. Bye.